Allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Okay. First item on our agenda, public comment. Do we have any public to make comment?
Don't look at me. You're here. I am
Just
here.
for
You're the only public chair that's filled.
Okay. Next item on the agenda is approval of the consent agenda. Did everybody have a chance to look at the minutes? Yep.
I move approval as presented.
Second, third,
Third. Been moved and seconded to approve the consent agenda as presented. All those in favor?
Aye.
Okay. December 2018 financials. Cheryl, are you ready?
No.
Okay. You're going to do it anyway.
Okay. Okay. Awesome. Sorry. Okay. All right. Good job. Okay, so for December, 303 total patients. Hospital was fairly busy, but ED and surgery were down, so, but really not a bad month, just a little bit slower. Year over year, we're down 192 patients, so about 10%. Most of that is in the ED, but also surgical instrument. Ancillary services, however, continue to be pretty strong. They were also down a little bit, but of course, you have to remember there's a lot of holidays in December. People don't really want to go to the doctor as much in December, so it does slow down. So still strong, still pretty busy. Year over year, there's a 35% increase in our ancillaries, so that's good news. Our monthly gross patient charges for the month were $3.076 million. Our average right now is $3.114 million. Year over year, we've got a 6% increase in gross charges. That's good news. Our collections on AR in December were $1.4 million, which is significantly below what they would be when you have a 6% increase in charges.
Right.
However, in January, we had a very good month in January, and we collected $2.33 million. 850 of that was from Medicare, because we were on hold for several weeks with Medicare. So that was quite a fiasco, getting that booked.
What was the reason we were on hold?
Because we filed our Medicare cost report late, because we had all the issues with Goose Lake at the last minute. And it was better to just go ahead and make those changes rather than file and refile the cost report. So it slowed down our cash flow for a while, but it probably saved us a lot of thousands of dollars with Whipley having to refile the cost report. So that was why that was.
Everyone remembers that one. It's just important to make sure that
Yeah, that was
there was some planned reasons why that occurred. Not that we liked it, but
No.
that's what I'm saying.
No. And of course, that slowdown in our Medicare payments. December, we were at 89. We jumped up our high of 102 at the end of January. And of course, February, that as of now, we're at 95. So we should be on our way down and stay going down. We won't have any more problems getting paid for Medicare, at least for now. So we've been very busy in the business office, kind of talking about what's working and what's not. And I've identified several problems that we fixed in contracts that need to be updated or created. And I feel like there's a really good attitude in the business office, and people are working really hard. And we've been meeting together a little more regularly, and I've learned a lot, and I do feel good about how how hard people are working, and they're understanding that we need to solve this problem, so.
So with the audit behind you, you're having more chance to concentrate on that area?
Yeah, I'm spending a lot of time in the business office lately.
Okay.
I've created spreadsheets where I'm keeping track of all the things I'm working on. I can send that to you just because I've kind of identified all these problems, and then I've been putting it at the bottom, and so I can kind of have a little checklist of, here, we finished this, and we finished that, and we finished this, and we are getting paid for Medicare Advantage finally in Alturas, so we've got some of those payments going, some of the commercial payments going. We still haven't gotten paid by Medicare, and I'll send you out tomorrow. I created a little, actually I worked with Carrie Cornelius, who does the work, who is going through all of the many hoops to try to figure out why we can't get paid for Medicare and mostly it's because Medicare is confused, and because Moss Adams didn't close a loop with the state of California, so this is causing confusion over who are you now. I thought you were Stevens Parkview, but you say you're Goose Lake, and now you're going to be Alturas Health Clinic under Love. I mean, they're very confused.
So Moss Adams is a couple of years ago.
I know, but they never, and then we're really confused as to why we even ever got paid by the state of California, because they screwed up. But the state of California is very screwed up.
If you recall, when we switched from Dr. Stevens to Dr. Gilman's, that switch was when Moss Adams was providing us services. And there apparently was a failure on their part to finish something we thought was done.
Well, yeah, because they were supposed to, you have to do an application for your payment. But since we were getting paid, we kind of assumed that got done, naturally. But it didn't get done, so then the state of California is confused about who we are and what's your NPI, because we are going to keep Goose Lake's NPI, their National Provider Identifier number. There's no reason for us to change that. But they're now billing under a different tax ID number.
So we're getting into the weeds here.
Okay,
We just
sorry.
need to,
I'll send you out the write-up, because I do think it's kind of interesting. If you have questions, let me know. I guess I want you to know that we have been working very hard on it. We follow up, religiously on it, to try to get it going. So I don't know how we could have done any more than what we did. And today they were closed because it snowed in Seattle, and so there was nothing we could do about it today. All right. Days cash on hand at the end of December was at 73.
This bothers me. So, comments, what do you think?
I think that it would be helpful if we could get our days in AR down, but it won't totally solve this problem. We need more profit and, so less expense. I did do the updated budget, so I can send it out to you guys, and probably you're going to talk about it at your planning meeting. You need time to look at it and ask questions, and then we'll, So yes, part of the problem is definitely our days in AR would get us closer to where we need to be, but it wouldn't totally solve this problem.
When you look across that graph, that started going down in March.
Mm-hmm. Well, then, yeah.
Almost a
Yeah,
year now.
Yeah. That it's been.
Do you have much more
Well,
from
so
Alturas?
the good news is we should be getting our $400,000 from our Medicare cost report. It came in, I would expect it anywhere from mid-February to early March based on when we've gotten it in the past. So that'll be $400,000. I did get notice that I'm getting $169,000 for a final settlement from state of Oregon for 2017. That should be coming in any time. Jake Greer has got $100,000, a little more than $100,000 that he's gonna give us because he got some grants and we're going back, it's almost gonna be like $25,000 a quarter, and he's able to go back 3 quarters. So that money I expect to be getting in the next few weeks.
That's related to the wellness
Right?
center.
Yeah,
Yes.
for seeing those clients.
It's part of the drug court. Part of our participation in that. Yeah.
But Cheryl, you said even if we get our AR days down, it won't completely fix this problem.
Well, I mean, we're losing money.
Uh-huh.
So this month, we didn't lose money. So obviously, when we're losing money, it's draining our cash if it's been in our savings account. So, which is kind of why we did that mid-year budget, to kind of really think about where are we and what do we want to do about, including that before the end of the year.
This is where recruiting a surgeon and
Mhm.
doctors
Right,
really would come in.
right. When we look at our P&L, so as I was studying that, the projected budget, one of the things that really stuck out to me is that there's two big things that are way under budget. One is the orthopedic surgeon. We didn't have the orthopedic surgeon. However, we do have Dr. Chang now, and so that means that instead of having a general surgeon 1 week out of the month, we have it for 3 weeks out of the month. It's not going to make up for an orthopedic surgeon, but it is going to make a very good impact, a positive impact. The Chang's just getting started. You have to give him time to build his practice. And, we had the OR remodel, so we slowed him down a little bit, but now he seems to be doing pretty well. The other thing is that we had planned on hiring 3 LCSWs to work in our clinics here, as well as a psych NP. We had a psych NP on board when we did our budget. Remember, he left. And so our clinic revenue is about $900,000 under budget because we don't have any of those 4 people. So, and there would be naturally there'd be some staff attached to that, but not very much. I mean, this is big impact. So we do have a psych MP coming hopefully in April, unless that changes, but they're coming.
As far as we know, she's even secured housing. So it appears to be no reason to assume that's not coming.
And we've had Jane Lincoln here for a few months, in LCSW, and so I would think that her practice would also be good. But it takes a little bit of time for them to get going. So, for the month of December, we were very close to budget for revenue. Our expenses for the month were $204,000 under budget. Our gain was $197,000. And our net profit for the month was $220,000. So that was a very healthy profit for the month. And so that impact on our year-to-date is we are $700,000 behind budget for revenue. And we are $285,000 behind budget, so less than budget, under budget for our expenses. Year-to-date, we have a loss of $15,000, which is $179,000 below budget. We'll be very interested to see what's going in January. Our expenses have been higher with all the moving that we've been doing and the growth.
Sure.
So now that people are settled, we better see that slow down.
Mm-hmm.
So, and revenue census has been good in January. So, we'll know soon. Balance sheet, really no difference month to month, except that our patient AR is terribly high.
That's the part.
Our fixed assets have gone up a little as we continue to pay for construction. There's another place we'll get some cash. We should be getting a final bill on the clinic construction, and we should be able to get several $100,000 from the bond on that. So I'm waiting for the final bill. We have to have Gene come out and do an inspection. And then we can borrow that last bit of money, and that should help our cash too. All right. So that's it for the hospital.
Any questions?
All right, so then we are going to talk about the patient monitoring system that we want to buy from Neon Coden that we did budget for. And I think that's about all I have to say about that, because Teresa's going to tell you how awesome it is, right?
I am.
Okay.
I do have the final number in front of me, and I didn't have that, so.
Okay. You want me to say that
We
first?
sent the packet to everyone, so you should have seen all that information.
So this is the cardiac monitoring system that allows us to see patients' heart rhythms in ER and at the nurse's station in acute as well as in OB.
In every room.
No, it's not in every room. We move the monitors from room to room depending on where we want them to be. There's the monitors that are bigger and take blood pressures and pulse, and they're on a cart, you probably seen those. And then we have the little telemetry boxes that just send the heart rhythm to the desk. It's all part of one system. And it's, like I said, it's at all 3 nurses' stations. And that monitoring system, which we installed when we did the move, was new to us, but not, it was toward the end of its manufacturing life for Mindray, the company that made it. So a couple years ago, it stopped being supported by Mindray, and we had to approach them for a special contract for service, which seemed awfully high for us. I think it's like $10,000 a year for us to get service, to get somebody out here, because that's not a system you ever want to go down. So just when we have a problem, we've had this additional expense, and they've told us that it's, they don't want to support it anymore. It's not been manufactured for several years. You better buy a new one, bottom line. That was a couple of years ago. So we, for the past year, have been looking at what we wanted to do, if we wanted to stay with Mindray or go with a different company. So we looked at 3 of the main, what we consider to be the 3 top companies. We looked at GE, we looked at Mindray, the company that we had for all this time. And then we looked at a company which isn't a new company, but it's newer in the cardiac monitoring business, and that's Neon Coden. They're the company that we got our sleep-lab system through, and we have been very impressed with their system. It's very user-friendly. It has a lot of the things that we were looking for, as well as way more responsive service. We've struggled with Mindray for a lot of years and not been happy with their service. So we ended up choosing the Neon Coden system. The quotes themselves from the 3 companies were relatively similar, although not exactly the same. Honestly, GE was less expensive. Mindray and Neon Coden were almost the same. Neon Coden did offer us something that Cheryl can speak to better than I, which is a subscription program. Can't talk very well. Which, from Cheryl's perspective, I mean, this is not, that was her call. She liked the idea of this program better and the way it's financed. So that's our choice. I don't know if you have other questions for me, if I explained it well enough.
How's it going to interface with EMR?
So one of the things that we know is that with a new electronic medical record, we would have the option of having all of the cardiac monitoring strips embedded inside the electronic medical record. What we do now is we separately keep those strips on paper, and they get scanned into the medical record later. So they're in a different part of the medical record and less retrievable if that patient comes back in and you want to look at what their rhythm was in the past or whatever. So that would be ideal. And if we were to choose that, Neon Coden is certainly very compatible with any of the electronic medical records that we would choose. It's an additional cost, and it is not going to be, it's called a gateway, so that gateway within the system, we would have to purchase that from Neon Code, and it would be added onto our subscription price, which would make the monthly price go up. But it's optional, we're not paying for it now, and it's always there and always a possibility. So we felt like that was the best scenario to not have to pay for it now. Which, again, Neon Code had offered that delayed option and the other companies did not, so.
So you're still talking about a cart system?
So the system, essentially it's the same idea. The monitors can go to any one of the rooms throughout any of the rooms, ER, OB, or any of the rooms on acute. So in that room, then you can see the patient's heart rhythm, you can get their blood pressure, you can get their O2 saturation, you can get, all of that barrage of vital signs, and then it transmits that to the central station. Or we can use their telemetry monitors. So the telemetry monitor, it's a little fancier than what we have now, so you can actually see some things on the box. Now we just have a box. But it, again, transmits the cardiac rhythm to the central station. And the central station interprets the rhythms and alarms when there's certain concerning or life-threatening events.
So this would be automatic when somebody comes in the ER, they're looked up automatically right away?
It depends on their diagnosis. Like if they're a patient who we think is critical at all, they're automatically hooked up. And then that's no different. It won't change our process.
Okay.
It's the same, it's just that we're sort of standing on shaky legs because our system isn't supported and it's old and it could break down at any time, and it's not a system that we want to have break down.
So how many patients can you monitor at one time?
I think we chose, it's in the quote, I'm trying to remember it. I think we chose 10 monitors and 4 telemetry, so that would be 14, and then another 5 in the ER.
Yeah, because it says
19.
16 patient central monitoring system. So
That's
is that
that's
16
how many.
altogether?
That's how many you can view at the central
10
station.
roll stand, 10, 10.
10, that's the roll stand, and then the telemetry boxes are 4. Sorry, I haven't looked at the quote.
I don't know if I speak this.
I'm not a
language.
numbers person, can you tell me?
What it really says is we can monitor people in a lot of different ways, which is something that we need to be able to do.
That sounds like a lot, but
That's what we have, I mean, essentially,
that's-
we're not changing our numbers much.
oh, okay. Do we ever use that many at one time?
All at one time?
All at one time? I mean, not that we want to do anything less, but I'm just curious about that.
Well, we usually have 2, 3 going on in the ER, and then we'll have several on the floor. Sometimes there's a patient in OB. Yeah, we don't usually have them all, but different patients need different things at
Sure.
different times, so some of that is the flexibility. So 10 bedside monitors.
Was there a difference in pricing, Lisa, if you went with 5 or 10? Maybe there were just,
No, this was based on, so that was another thing that they did, was they came in and really looked at our processes and gave us the number that they recommended, rather than just trying to sell us as many as they possibly could. So they sort of evaluated our processes and gave us their recommendation. So, yeah, 4 telemetry monitors, so, and then a central station in each of the 3 nurses, nursing stations is the rest of the quote. So,
And can that be used on a baby?
yeah, different hookups,
Yeah.
but the same monitoring system.
So Teresa, the central station, is someone monitoring that? Does it monitor itself and then alarm?
Well, it alarms. Yeah,
It
it
alarms,
makes
okay.
different alarms for different types of rhythms. In a perfect world, in the larger hospitals, sometimes they have a person who sits there all the time. We watch it, and we listen for the alarms, and we keep track of what's going on, and everything that happens is retrievable, so we can go back and catch stuff, because it has a memory. So pretty much, I mean, anytime you go, if you're in another hospital and for a cardiac event or whatever, that these are sort of standard equipment to monitor patients.
So in a case like this, sounds like something we really need. What do we do with our old ones?
That's really sad, but there isn't anything you can do with them.
It's just
People
not even
don't-
surplusable.
We might be able to sell the rolling stands, although I haven't had good luck selling medical equipment. So it's really hard. Some of those rolling monitors that we currently have might be able to sell them for a little bit, but not a lot.
And what's the numbers?
We budgeted $275,000 for the system. This system came in at $292,000. So that means what we generally do is look at the budget and say, what are we going to take off the budget to make up for that shortfall?
Off the capital budget, yeah.
Yeah, sorry, you're right, the capital budget. And there's a striker set of ortho drills and saws that we were going to buy for $37,000. That, probably that's an easy thing to push off, because even if we do get an ortho surgeon, they probably won't be buying that stuff at least till next year. So,
What we had put there were placeholders. We don't really know what they're going to ask for. So,
It's, as I read it, it looked like you were going to pay this over time.
right, yes,
Yeah,
yes, so the thing that they offered us is a subscription, and it looks an awful lot like an operating lease. And so there's just a monthly expense. There's no there's no ownership, and there's no recording of the big debt. So I have a feeling that that might be a loophole that's closed at some point. I mean, I think the whole point of this is to sort of get around some of the new GAAP rules that say you have to treat everything like an
Is it
asset.
financing lease, then it would have to be capitalized?
Yeah,
You
well,
might talk to
no.
Whitley.
Huh?
You might talk to Whitley and see what
Right,
those are.
yeah, I might. But they call this a subscription, and there's no ownership. And of course, one thing we consider much is, are we gonna want it at the end of the term?
Which is 6 months of that.
Yeah, and
And there's full service, that's the other part that we,
Yeah.
they leave an extra monitor and a portion of the central station on site, so if anything goes wrong, our maintenance staff can substitute that automatically, and then they put one in the mail, or they send a technician on site within 24 hours. So we felt really good about the service that we have embedded into
And
the
it sounds like
subscription.
service is more important.
It is really important.
Are
Yeah.
we close enough to get service within 24 hours to anyone?
Yeah, I think they're coming out of Portland area,
Oh,
so it's
When-
not that far, but
when we buy our MRI, CT, any of the big equipment lab, same thing. They have technicians that come on Bend, and they're here. And we have, in the contract, they have to be here within a certain time. And sometimes what happens is they can get here, but the parts can't get here.
Yeah.
And so, I mean, it's a combination of things. But we specifically put in their response time requirements.
What's the lifespan of your old system?
well, how long have we been?
Well, then 5 years.
2011?
So
it's
8
8 years.
years. So it's 8 years old, and unbeknownst to us at the time we bought it, it was right at the end of its manufacturing life. But essentially it was, I mean, everything about it was new at that time. And, 5-6 years is what a monitoring system lasts, so have gotten our, it just seems horrendous that that's all the longer they last, but it's true.
So if you're doing a 5-year subscription, is that what you're talking about?
Yeah, so the monthly expense is gonna be $4,881.
What's that mean?
Pardon?
Annual?
Monthly,
No,
monthly.
the
Oh,
annual,
I don't
$60,
know.
just shy of $60,000.
Yeah.
Yeah,
Okay.
yeah.
So that's not going to kill your cash flow too bad.
Well, yeah, it's actually lower payments than the lease for, purchase lease for Ben. And, yeah, I am kind of focused on cash flow right now.
But it does add to the Medicare cost reimbursement.
Yeah, yeah,
That's a delayed,
yeah. That's true.
delayed pleasure.
Yeah.
Well, it sounds like you're recommending this, so I think the motion is we go ahead and approve it.
We are recommending.
Is this something that needs to be done now, or does this go in the budget?
It was budgeted.
It was
It's all,
budgeted.
okay. in the
Yeah,
capital
it was
budget.
Yeah, it's a little bit over budget, so we're kicking off the surgical tools out of the old budget.
You are.
Yeah,
Yeah.
we're not going to get the surgical tools in order to be able to afford this.
So just to be clear, if it's in an approved budget, we don't have an obligation to take it. We can
Right.
just go
Yes,
ahead and
we do.
do that. But whenever there are big expenditures, especially if, when we made the estimates a year ago at $250,000, it's a little bit different. What we wanted to do was make sure that there's no surprises. This is what we're doing. And that's why we are going through this process.
I was told this, whenever you put a yellow marker on there, we have to have a motion.
That's true. Technically, you don't need to, but we
Sorry, that's my
appreciate
fault.
when you do.
That was me.
Ken?
I was happy with the yellow.
Okay. Okay, so this is just for information only, we don't need a motion.
We don't need a motion.
Okay,
But
All right, I'll withdraw my motion.
good. Okay, any other comments on the patient monitoring device? Okay, the budget calendar.
Yes, I'm sure
Everybody
you
should have gotten
studied it, right? The budget calendar. It's really the same as last year, except that we will have a completed draft of the budget 2 weeks prior to the budget committee meeting.
Rather than 3 days.
Huh? Oh, yeah, that doesn't need to say that.
Okay, good.
Yeah, you're right. That was Joey's fault.
So we do read these things. Good catch.
one of the things you'll learn very quickly is if you're not here, you get blamed.
That's right. Yeah, so I'll fix that. Otherwise, the dates should be good.
Okay, this one does need. a motion.
Yes, it does.
Yes, it does.
Go on, talking. Okay, I'll move to approve the budget calendar as presented.
Okay, been moved and seconded to approve the budget calendar as presented. All those in favor?
Aye.
Passes unanimously. Thank you, Carol.
All right.
Okay, you're still up. Next item is the East Lake Medical Services.
Yes. Okay, so in Lakeview Gardens, census was down a little bit in the long-term care and it was up a little bit in assisted living. Actually, year-to-date, our total patient count is 4,697, or days, I should say more accurately. So year over year, in total, we have 216 more patient days than we did last year. This time, it's good.
How many people in ALF now?
10 extras that are on the bridge.
So we're getting close to full service. All right.
January revenue was $180,580, which our average is $189, so pretty close to average. For the month of November, our wages were down a bit, which is good news. There was a correction in the PTO for this month. The contract labor is still pretty high, but not higher, so the loss for the month was $84,000. The loss for the year then is $822,000. Medical supply had another good month for revenue. We're also still paying our consultants, so we actually lost $1,719 for the month. And so then, as promised, I thought I would tell you a little bit about our consulting project that we did. The man that we worked with, his name was Stephen Baker. He's from the East Coast. He's the president of his company, HCEA. He's been working in the business for 40 years. He specializes in DME equipment and actually has quite a bit of a network of people that we're going to use to help us improve our business. He's focused on preparing us for our accreditation visit that Medicare will be visiting upon us very soon by mid-year, and also looking at recommendations to improve our business revenue. The phase one, the first week he was here, he looked at, his recommendations are, he said our policies and procedures, we have too many of them. You should only have the policies and procedures you absolutely have to have, because if Medicare is going to come out and see if you're doing what you said you're going to do, so we need to fix that. Another thing that we already knew is the DME Works is the billing software that we're using, and it's absolutely awful, and we're losing money, so we are losing billing. So we are in the process of moving to Brightree, which is a much bigger organization, and so that should result in higher billing and less missed charges. He believes that we're short-staffed and we should add a full-time customer service position, job descriptions. He says, rightly so, we need to improve our working relationship with our clinic, mainly our own clinic, interestingly enough. He suggested some very good ways for Brian to network within the industry and meet new people and attend this Heartland conference, which I guess is in the middle of nowhere in Iowa, but apparently a really great place to learn a lot, what you need to know about business and whatnot. He says we need to be more supportive of them. He's helping us solve the problem that we have just discussed before, is how, which my Whitley could not help me with, but I have all this stuff in inventory and you have to depreciate it. I mean, it doesn't, I know you have equipment and I lease it out to you for several years, but I own it and it has to be devaluing, and we haven't been doing that, and so he's helping me understand what I need to be doing. And he did not feel that we are really much in need of a retail space. It's not doing us much good. We're not making a lot of money off of it, and it's really inadequate. There's not nearly enough storage space. That was his opinion, so.
That's in the old Elks building, right? Downtown?
That's great.
Next to the pot store.
He suggests we move.
He's saying you don't need a storefront? Is
Right.
that what you're saying?
Yeah. That we, he thinks we'd be better off having some sort of space here on campus, that people would utilize it more. It doesn't need to be a fancy looking storefront. You could probably sell a lot of the same stuff. He feels like the things that we're selling in retail are really not making us any money. Like he told us we shouldn't be selling scooters. It's not. You can sell a scooter, but you shouldn't have it in inventory.
Oh.
Or like those recliner chairs. Fine, go ahead and sell them, but you don't need an inventory of them.
Where would they go on campus here?
I think you guys have, we have ideas.
Charlie
You don't really want to talk about that right now, do you?
No.
Okay. All right, the second week he was here, this was more focused on improving our business. He told us that we should be making a lot more on PAP supplies, the PAP machines. Thank you, CPAP machines. That people use at night, that there's a lot of potential there. He said there's a lot of potential with backlog in sleep lab. We really do have, as we all have talked about many times. And when we had that second sleep lab person in December, we really saw quite an uptick in business. It was very good. I'm working on it. He says we could make some money in negative pressure wound therapy business. We already talked about our manager needs more training. Look at off-the-shelf orthotics business.
choose more carefully what you buy. He said that our oxygen model is not really the best thing. He recommends a little bit less of the portable units and more of the larger canister units, and that you still have the portable, but the other units are better for people, and they're better for, those portable units are horrendously expensive, and really, you can't make money on them.
You're talking about concentrators?
Yes, thank you, concentrators, the little things. They're very nice to have, but they're extremely expensive, and you don't get reimbursed very much for
With
them.
the other units, are you still talking about a concentrator that goes on the floor?
Well, there's a larger unit, and then there's also oxygen delivery, and I'm not really,
There's
Yeah.
bottles.
right.
Right.
A lot of what he's talking about is fine tuning how we're doing this.
Mhm.
So it's not like we're doing anything wrong. It's just these are ways to make it better and adjust some of the things. A lot of it. I mean, and looking at the report, he's got a lot of really good suggestions for us.
He does, like his anchor delivery model. So instead of, you can ship things directly to patients, you can put closets, like orthotic closets. A lot of times if you go to a clinic, they have an orthotic closet. So instead of you having the patient come to you, they put it, the doctor gives it to you straight out of their supply closet, and then you bill it, rather than us having to deliver all this stuff. So, and then, of course, we talked about keeping him on for 6 months just to answer questions. Naturally, I did feel like he was a very, very competent and down to earth. I mean, I didn't feel like I was, what he said made a lot of sense to me.
So
I thought it was good.
if you, on your bookkeeping, depreciate, then our bottom line is gonna get a little worse.
That's right, that's exactly right. But when I look at it, I don't quite know how to do it, but I know it's wrong, so I keep.
Well, everything's got a useful life.
Right,
You're
yeah.
using that.
Yeah, exactly.
So on that, the depreciation, is that also cost reimbursable, or is that outside of the? Outside.
Yeah. Well, that's all for me.
Okay, thank you very much. Mr. Twait, the Cancer Travel Fund Policy. You have a copy of.
We sent out a copy of our cancer travel reimbursement policy, and I think there was some questions about how that policy works, so we have a little bit of information for you. As we have received more and more monies for this fund, we want to make sure it was clear and readily available. So this is more of just informational only. But it helps everyone understand we do have a policy, we do have a process. And because now we have more of them to disperse. We want to do it in a fair and equitable fashion.
Where does that money come from?
So
Donations?
there have been donations, and there have been many members of the community that have been donating to that fund. So as we accumulate more money, we want to make sure we're dispersing it.
Committee does fundraisers as well.
Sorry?
The committee does fundraisers as well.
Any questions about the policy? And that's readily available.
Okay. Code Gray.
So this is we sent out a packet of material to talk a little bit about an issue that has become more and more front and center. It is certainly exacerbated by our town not having strong police. County has been participating, but as that happens, and then of course, more and more, as we are becoming more and more attuned to the risk that members, especially nurses, are facing when they're here by themselves. A lot of times, we even actually had to have a survey to have nurses tell us when they feel unsafe or might be at risk, because they don't talk about it. It's almost a cultural thing, where nurses accept that that's part of their job. They're interested in caring for people, and if somebody makes them anxious, most often it's because they have a medical condition that makes them present in a frightening way. So these are things that, as we look at it more carefully, thoughtfully, we need to do something about it. So a group of members of our hospital management team and others have looked at what would it take to provide more security. And in that report, you see that the recommendation is that we hire a security officer to be present from 6 in the evening till 6 in the morning, Monday through Friday, and then all weekend long. There are other hospitals that are doing this. Urban settings, it's to the point where some of the bigger hospitals actually put a police station in the hospital, physically located there. Those that don't have police vehicles out front, and it's a show of force, because there are people that make this, that aren't just making the staff feel nervous, they are dangerous people. We have, and of course for us here in Lakeview, we need to, our sheriff's department is not comfortable being available to provide us with support as much as we'd like. So I think as I look at, I mean, I've been hearing this for some time, and it's hard when the answer is always, well, the hospital has to hire me. But there isn't anybody else that's going to do it. And we have to take care of we have to keep our employees and our patients, but mostly our employees safe.
Do we cover this cost with our cost report?
We would have, I mean, there are a lot of things that, as we do create job descriptions for what they would do, there'd be a lot of things they would be doing. But no matter what, they'd have to be able to respond very quickly to the place where we would have greatest risk, in the emergency room, on the acute floor. Those are generally the places that we would, at night and on the weekends, need to be able to be present. If they're doing rounds around the hospital and checking for things and doing some things that might take a little time, they have to be able to drop them at a moment's notice and be back at a place where there could be a problem in very, very quick time.
Could you ask the city to park one of their older cars right out front somewhere with it? A little deterrent.
You can. You know, the police talk about how those people that want to do things that aren't right, they will place them up on black cap with binoculars and advise the others, their crew, where the police are sitting in their vehicles, so that if you place a vehicle, you might just be placing a vehicle, taking up a parking space, because somebody figures it out pretty quickly.
And I noticed in your report that this was unarmed people.
There aren't too many hospitals, especially in rural settings, that believe that arming a security officer is a good idea. There have been talk about providing different kinds of protection. Generally speaking, the least amount of threat is better. Now, in keeping with this, This isn't the only way that we protect our staff. There are trainings and classes that we can take. We have used and trained lots of people on ways to deflect and reduce the threat when something might happen. But as part of this, if we're going to hire some people, we would probably train our staff and have a lot of our staff trained in different kinds of programs. We've specifically identified a program called a FAID that has been found at other facilities to be a real good way of providing a deterrent to someone who might be prone to doing something inappropriate, and do it in a not non-threatening, but in less threatening, and that helps reduce the anxiety. I mean, when you present as a show of force, that either deters someone or escalates the situation. So you want to be mindful how you present. So we would be involved in hiring people plus training our staff.
So this is a proposal right now that you're looking into, that you integrate into a budget for next year, if you want to go forward with this? Is that what you're looking at?
We would put it into the budget, but we would move faster.
Oh.
The need has become greater, especially with our present police force. It has made me more, not anxious, but has made me more concerned. Are we really protecting our staff? There are a lot of things that we have done of recent that create greater opportunity for escalation. We've been more restrictive on our opioids. There's more access to cannabis. Cannabis has been, or THC, has been shown to increase the likelihood of people that are prone to have escalating experiences. They become escalated quicker. I don't want to be coming to you and saying, I can't believe we didn't do something quicker because something terrible has happened.
Teresa, do your night people in Cuba feel unsafe? Have they had incidences? Like, what's an example?
Lots of things happen, and I was telling Charlie, I don't always even know because of the culture. Because in nursing, we deal with things and we don't always consider it out of the ordinary. So it can be anything. It can be somebody who comes in high on drugs in the ER who's violent and difficult to deal with. It can be somebody who comes in with somebody in the ER who's violent and threatening. It can be the significant other of a patient who's in labor, who's high or threatening. It can be, certainly our mental health patients are a frequent issue. So, you know, when we have patients that are a danger to self or others, we lock them in 107, our locked room. And it's not uncommon for those patients to be threatening and yelling and hitting the doors or breaking out the window, which is what happened about 6 months ago or whatever.
As an example, Teresa gave me a list of just in the month of January. Won't give names or.
Charlie, can you talk up just a little bit?
I'm trying to, sorry. There were patients that used a lot of verbal threatening, and sometimes those can escalate very quickly. There was a patient, as Teresa said, who was in the hospital, but an agitated, interested party, like in a new delivery, the father and child, not spouse, presented and was intoxicated or had some medication that was altering their act. And they presented in a frightening way. And these are examples that made our staff very anxious.
Well, and the other question I had, because I think I read it in something that was sent to us, is are there people that just wander around the hospital at night and we don't know where they are and why they're wandering around?
Well, that's a difficult problem in that even though we lock the doors at night, there's no sweep of the facility. So is there somebody hanging out in the bathroom? We've had people who spent the night in the chapel, people who spent the night over like in the entries to the clinics. So we don't have a process. We just sit over there in acute and do patient care, and there's this whole facility which actually is sort of unchecked and unmanned and unsecured. Sometimes the doors aren't closing all the way, and nobody knows that because we don't check them.
Another part of the culture that nurses have is if someone presents in the emergency room but is homeless, they get discharged and they may be saying, I'm waiting for someone to pick me up. Nurses believe them. And that person goes and sleeps in our waiting area, or sleeps in our, or it's snowing outside. Nurses aren't prone to kick people out. I mean, that's just not in the culture of caring for people. And yet those people may or may not be safe. And that makes people feel even more unsafe. So there are, and it's becoming more of a more frequently occurring. And again, these are not real frequent experiences, but when they are occurring, that makes a lot of people feel very anxious.
I would be concerned if your security officers didn't have some form of restraint, taser or something. Maybe we don't want to shoot people, but we want to stop them if they're doing something that you physically can't stop.
Would they have access in some quick manner to get whoever's on call, or local police, or somebody, a sheriff in here if they need it?
No matter what kind of security we provide, we always have that emergency button to call 911. And at no time have any of our police officers indicated a reluctance to come. So we still have that.
Why?
Sometimes they can't come because they have another call and they have to prioritize the calls. And that's certainly one of the things they've brought to us. We've had 2 sort of community type meetings where they express their concern about the security of the nursing staff. Speaking about law enforcement, had these meetings with us. And I mean, they're happy to come, but they don't feel that they can always be available. And one of the problems that we have is if we have a violent patient who's locked up in 107 and we have to administer medication or go in the room, so you've got these, just to stereotype, 2 little nurses on night, females on night shift who have to open the door. So our only option has been to call law enforcement to accompany us in the room. But they aren't always available because there's another call about something that maybe can't wait, and they figure our situation can wait. So they're constantly juggling this issue, and they feel like it's more than they can deal with. And so then that even makes us feel less secure because now the thing that we used to be able to call on is less available.
I get that. I don't blame you girls at all. It seems, I'm with Chuck. I think a security person should have some means of protection, some means of whatever. I mean, good grief, when we started the school resource officer, they carry a gun in through school for several years. How is it different?
I think that we should follow best practices for
Yeah.
hospital security.
Many of the officers carry flashlights, big flashlights, and that helps to detain. And there are other ways. I mean, the hardest part that you have is if you want to fight force with force, you start escalating things. And the last thing we need to have is somebody who thinks they know how to use a gun, but don't use it on a regular basis, and somebody who does. Now we have a much greater problem. So I'm not terribly, I believe best practice is the right thing to do, but I struggle with having armed security.
So you're really not looking at a police officer. You're looking at a security type person
Yes.
that is trained in a different manner.
And trained to try and de-escalate as much as
Okay.
absolutely possible, but provide support to our nurses and train our nurses and other staff members on how to de-escalate issues. And really, that's the optimum.
So you're looking at 2 security officers for each night, right? One?
One from 6 in the evening until 6 in the morning,
12-hour shift.
12-hour shifts.
In daytime, nothing.
Well, no, we would have staff trained during the week. We have a lot of people here.
Right.
But there are times that staff members are called to help in what is called a show of force, where people help to de-escalate it. Sometimes just the presence of people helps de-escalate things.
So some of the studies have shown that a show of force is almost always a de-escalation in and of itself. So if we have a code gray response team much more formalized and trained than what we have now, so if we utilize the training to help people know how to deal with violent people, and they're willing to be part of our response team, if, 6 or 8 or 10 people show up during the day as a show of force, that in and of itself should be very helpful during the day when we have those people to respond. At night, we don't have that.
Another part of this is a person could just be agitated and not need to become violent. If we could de-escalate them from being agitated, we reduce that opportunity for violence. And we often have people that are agitated for whatever reason.
So overall, in the proposal, we'd probably be adding 3 or 4.
3.
And then you have to plan on somebody being sick or
Right.
vacation and that kind of thing.
PTO.
And it isn't maintenance. Oftentimes people say, well, it's the maintenance guys that could come in. Well, they don't necessarily want to be placed in that position just because they're a male.
Well, they're not trained in that position.
Even if we train them, not everyone wants to present themselves in that position.
So what is your thinking process about hiring these people? Can you hire security people? I mean, I know you can, but probably out of area, or do you hire people who are interested in the training? Or maybe both?
We would certainly talk to people that, say, work in prison, that might like to supplement their income and work as a part-time. We would talk to people that would like to be a security officer and prefer to work 3 days, that's 36 hours, and have 4 days off. I mean, there are going to be people that present in a variety of different ways. So I don't know exactly what
Already got all the city cops.
Well, I'm all about protection for this hospital and the staff, so.
Get some old fishing game in the dark guns.
So going forward, this is not something that we're going to vote on, but we're going to look at going forward, putting this in
We would start right away. We did not budget for the staff. We will for next year. But at the recommendation of the co-creative committee, that recommend to me that we do this right away. I believe in the interest of keeping our staff safe, keeping our community safe when they come, that we need to move on now. And it's taken me a long time to get to that position.
Yeah, you've talked about this before.
Yeah. Well, and it's become more critical as far as police officers.
It is, and that certainly has swayed my opinion.
Dave, how about you? Would you like a part-time job?
I don't like to stay up that late. I can tell you that Gerald, when I talked to him 2 days ago, said he would be in favor of this. Thank you.
Thank you.
Thank you for your support.
Okay, Teresa, you're on with the nursing report.
Okay, well, I have somebody here with me to meet you guys. This is Erin Wells. Unfortunately, she's a little bit under the weather this week. Starting a new job, I guess, gives you a cold. But this is our new clinical nursing manager. She's just starting her orientation and trying to learn about our culture and kind of the oddities that go along with the rural hospital. And I don't know if you want to just say where you came from and what your background is.
Sure. So you'll have to excuse my voice. I came from Scappoose. I don't know if you guys know where that is.
Oh, yeah.
So I know a little bit about small towns. I know you guys are a little smaller. But I worked for Providence before. I started at St. Vincent and did med-surg. And then I did critical care. And then I did informatics. And then education. And then triage nursing is the nurse advice. So I figure a little bit of everything, jack of all trades. And then I wanted to move to a small town and have some land and have lots of animals. And Teresa's been joking today about me shooting things, so we won't go into that right now. But yeah, so I've just been enjoying getting to know the hospital and this town. So yeah, it's been great.
So what?
Oh yes,
what does
I also
she
own a business
do
too.
that helps you?
Well, she'll be the primary supervisor of acute care.
Okay.
So, or at least that's our goal. That's what we think we want her to do.
It
That's
changes
what we
every
hired her
day.
to do. So she's, I mean, it's a long process because part of her responsibility is taking call. And taking call means you have to be able to care for patients in all the areas that we have. So it's two-pronged. She has to learn the clinical part as well as the management part. But she will ultimately be the person who directly supervises the nurses, the CNAs, and the unit secretaries on acute. So it's a big job.
Good luck, Erin.
Thank you.
Welcome aboard.
Thank you.
Yeah.
Glad you're here.
The other thing that we have to report, and I guess a certain amount of this credit actually goes to Charlie, but he asked me to announce that the Klamath Community College has selected a new director of the nursing program over there, which we are very excited about. Her name is Allison Sansom, and she won't start until summer, but she comes down from Astoria, and she's been supervising, which program, Charlie? The Clatsop Community College, and she brought on the program that a lot of the community colleges and university have, the curriculum that a lot of those programs use for nursing. She brought that to the Clatsop Community College, so we're very hopeful that she will be doing that at the Klamath Community College. So we're thrilled to have the fresh fresh start
So
with
she's
them.
coming here?
No, she's coming to the Clemens.
Clemens. Okay.
Yeah, so she'll be the dean essentially of the nursing program over there, starting in June, I think. So that's really good news for us. We're delighted. So I think those were my items.
Okay, any questions for Teresa? Thank you very much.
Yes, thank you.
Medical staff privileging. Without Dr. Hussey here, I assume.
Dr. Hussey was not able to be here tonight. He apologized, but there were things that came up. So we sent out to you a copy of all of the either original appointments or reappointments. Dr. Chang is an original appointment. Lisa Cahill is a reappointment. Christopher McAllister, reappointment. And CRNA Barbara Lodermo as the reappointment. Medical staff recommends that you approve these applications.
So moved.
Second.
Okay, been moved and seconded to approve the medical staff privileging as presented. All those in favor?
Aye.
Passes unanimously, so we've got doctors. That's good. Employee recognition. Charlie.
So as every month, it's a great opportunity to highlight someone who has done exceptional work here at the hospital. As you know, we had a change in the business office recently, and as Cheryl has described, many of the staff members have really kicked it up a notch and really worked hard to try and bring many of our issues to fruition. One of our staff members, as an example, we got a Medicare check for about $150,000 with, I think there were 600 claims.
Yeah, praise God.
A great deal of claims.
Messed up.
And it was really confused. The staff member was able to get all of the bills posted and set within a very short time period, just a couple of days rather than weeks. Her name was Nicole Murphy. She is our employee of the month in the business office. Nicole really has done a good job, and she has a great can-do attitude. And that really is helpful to all of us.
Do we have a position open in the business office, or are we filling the position? Are you doing, or there is an opening there?
Oh, yeah, we've got the job posted, and we're actually short a staff person, and we've got the job posted for the manager, and another position, so.
We have 2 positions open?
Well, we never did fill when Tara left, so we've been short a person. We are making a lot of changes, so I'm not sure how that, I would hope that would help us to become more efficient, maybe not need that second person. We've got a few people, like Vicky's going to be retiring in the next 3 months, so we're working on training and transitioning for her. And then Barb LeClaire, sadly, her husband got a job on the coast, so she's going to be hanging. So we're going to make some changes and transition there.
But yes, we do have a position posted, and we are looking.
Receiving messages.
Okay. Well, congratulations to Nicole.
Thank you.
Next item, CEO report. Charlie, you're up again.
First, I want to say that Jane and I just got back last night from, kind of late last night. Jane, I'm sorry it was so, from the American Hospital Association Rural Health Conference. There were a lot of good things that Jane, I don't know if you want to talk about tonight, or we can talk about.
I'm guessing if we're going to have the
There were a lot of really good ideas that were coming out, and there is value in having, it was interesting, there were 900 people at 900 to 1,000 people at the meeting, 30% were board members. So a lot of discussion about role of board, function of board, how does the board think about directing organizations, and how to create and get lots of different ideas about how to help organizations transition to where we're going to be next.
I will tell you one thing. Jamie Orkoff did say that elected boards can function quite well in small, rural, isolated communities.
That's us.
That's us.
Are we functioning well?
Well, they can. I do not say they always do.
You may recall that he felt that the model was absolutely inappropriate for hospitals.
Is this the same fellow? that is
Yeah,
up
that was
there?
in Burns,
Burns,
yeah.
He's from Chicago.
But he wasn't the only one that talked.
Yeah.
So there was a lot of good ideas. But thank you, Jane, for taking the effort to go to that and to help bring back lots of good ideas for how we function going forward. And that all helps us all. I know we only met 2 weeks ago, January 21st, when we had our auditors here, so it isn't like you're not seeing enough of us, but we have had a lot of things going on. Our meetings with the Lakeview Disaster Unit, Chuck, you've had an opportunity to participate, Don, you didn't participate. The position that we're at right now, just to reiterate, the board approved a budget of about $950,000 to build a ambulance barn, if you will, a steel building housed over at the southwest corner of the property. We've been meeting with Darrell Anderson and his staff to try and ferret out what the Lakeview Disaster Unit would like. It's something, of course, what they like is more than we can afford, so we had to pare that back, come up with a reasonable estimate of what we think could be drawn, or what could be done. Darrell was going to put together enough of a set of plans to present to contractors. Detroit has expressed interest, as has Thornton, to build this building. If we come back with that kind of plan, if we can afford it, we'll bring that to you. If we can't, we'll have to make modifications. The disaster unit has talked about the possibility of putting some of their money into the building. They talked about possibly lending district money rather than just gift district money. So these are discussions that we are having. Not sure I have a clear answer.
They're talking about lending us money
Yes,
to build
as part
a
of the
building
construction.
for them.
But our payment to them would pay the rent to pay to us, if that makes sense. So it's a toss-up. Because they have to rent the building
This
from
is-
us.
Wow.
It's just
The
one of the,
concept.
it's just a proposal on the table. I
Yeah.
don't
Okay.
know.
I am not, we are not anywhere beyond,
Okay.
we have a drawing, we have, Darrell is working on coming up with some, enough information to get construction fixed costs. See where it goes from there. Our goal was to have it done by the end of January. It's the first week in February, we don't have plans yet. Know that they're moving as fast as they can to come up with that and get that to various contractors. Okay? I'll give you some good news that I'm pleased about. We received a grant of $89,500 to, and I think I sent out a copy of this to you. So that's kind of exciting to find these programs. This is specifically for dealing with, in our wellness center for parents with children, an interactive program. It's pretty exciting stuff. They're willing to support us.
Will that
Projects.
require hiring more staff?
No, it's using existing staff. And a lot of what they would be doing is children that are having challenging issues, typically mental health issues, and the therapist is providing some support. That's helpful, but if the parent is doing that and the therapist is talking in the parent's ear saying, how about this, or try that, that really helps the child. And so these are proven techniques, and setting up the environment to do that is really what we're talking about. So that's a really great thing. We are having some building issues with our new clinic and our long-term care facilities. So you may be hearing a little bit about that. Temperature is not exactly controlled the way we would have liked. So we have some frozen pipes. Because the weather's been cold, and we have engineers and architects, and lots of people. We're not at all happy. So it's just one of those things that keep us jumping around.
Will they warranty the work?
Do they have a choice? The answer is absolutely they will warranty
Okay.
it. And they will fix these problems. These are engineering issues. So, and we're being firm and adamant about having them addressed right away.
I seen him by the front door working tonight.
Well, the pipes that froze were our fire suppressant sprinkler systems. So we had to drain the lines, and they're now putting in the new heads, because when they leak, they're no longer, they don't work. So they had to fix them. So I don't need to bore you with all the details, but if someone makes any comments saying it's cold, the answer is yes, it is. And is it supposed to be that? And the answer is absolutely not. So, other than that, I will send out, just for your reading pleasure, the grants that Christy has been working on. I think that when I've sent them out in the past, every time I read them, I'm astounded at how good we are able to find outside money to support our efforts here in the county. She's really been a gem, and not only asking for this, but then, remember, it's one thing to get the money, it's nothing to spend the money and prove that what we did with the money was what we were supposed to do. So it's a process, and that's adding a lot of value to our community. We should be hearing soon about our CCO grants. They were due at the end of the month of January. Those are the grants that our vendor has used, along with the clinics and a lot of people to try and encourage CCO members to come and get care. So we apply for that every year. There's more and more monies. CCO 2.0, you may have heard about this a little. We talked a little bit about this. Those grants will be coming out, and the Oregon Health Authority will be issuing them effective, I believe it's January 1, 2020, because those who are finished. There's going to be a whole lot of shifting around. Who is going to be in the CCO? Well, Eastern Oregon probably won't see a lot of change, but as soon as you go west, there'll be a lot of change. So having a little stability for us is a good thing. Other than that, I don't have anything else to talk about.
Do we have something for executive session?
I don't know, do we have anything for, anybody have anything, burning issues that they would like to talk about?
Okay. If there's nothing else,
Oh, wait a minute, I have another thing, I'm sorry.
I have something too I wanted to. We did do something for Gordon Inslee.
We are going to be, we have sent flowers, and then there's been talk about that there be more of a memorial.
Is that a possibility? Can we do something like that?
We can look into what that would be.
Okay.
Of all the people that have suggested we do something, I haven't had a lot of concrete answers. Frankly, I'm not very good at suggesting, because I don't know.
his ceremony is tomorrow at 1 o'clock at the Presbyterian Church.
So we can talk about that at a later time.
We can,
Okay.
we can. So I know there have been many people that have suggested we do something, and we just need to ferret out what those would be as suggestions.
I have a suggestion, but that can wait.
One of the things I wanted to talk a little bit about as we think about strategy, now is probably as good a time as any, we need to think about the cost and to move forward with additional recruitment of physicians. We've tried to find another orthopedic surgeon, and I think the only way that we're going to do that is to engage a headhunting firm. We need to look at adding another practitioner in Alturas now that we have changed our financing for that community. We have found physicians in the past. It's not easy to find people that want to go to Alturas, but I think we need to step up our opportunity, our efforts, and find someone. The physician that I was talking with to come out here this summer, hopefully fall, Dr. Fox, who is finishing up her fellowship in obstetrics. She chose to stay closer to home. She's from Western Pennsylvania. I think we need to find another physician that will deliver babies. So the cost to do that is not small. There's the fees to engage these search firms. They charge a lot of money. And we could easily spend, with the fees, relocation costs, bringing physicians out, upwards of $150,000 to bring those 3 practitioners here. But I think that a failure to do that is going to put us further and further behind. One of the things that has made a difference for our organization and our community is the more that we can keep people from leaving our community really makes a difference. People that get their health care here are less prone to go shopping and spending their money elsewhere. Not every specialist can we get here. We have a hard time finding lots of specialists that come here because they're overwhelmed in the communities they're in. I could list lots and lots of specialties where that's a real problem. Someone recently said to me how it was just enormously frustrating about neurology, how we couldn't get neurological consults out of Penn or out of Medford. Neurology alone in the Bend area, the neurologists are operating at 150% of capacity, which means that they have 50% more than they can handle just in the Bend market, let alone want to come here. So Bend has that same problem. How do they find these specialists? What will make a big difference for us is having primary care physicians seeing our patients. We have been fortunate in that we've gotten several extenders that have come on board or have expressed interest in coming to Lakeview. Those are the nurse practitioners or physician assistants. And they really offer great support to our our physicians, because they can see those patients that don't require as much of the specialty services and knowledge that our physicians offer. But when it comes to obstetrics, it can only be delivered by a physician. And that's hard to do. And we don't want to get in a position where our physicians say, I'm done, I can't do it. Physically and emotionally worn out.
Chairman, there's, I'm trying to think of the terminology, people that do birth babies that aren't midwives, that's what I'm trying to say. Is that something that hospital can use?
They can. The challenge with finding a midwife is midwives are marvelous at delivering non-complicated patients. But the problem that you get into is then you'll still have to have a physician on call in the event something happens. And so you really don't solve the problem for the physicians because they're always on call. And that being on call is just an enormously draining process. We learned when we had CRNAs and we only had one, how difficult, I mean, that was marvelous to have that kind of care, but it was draining. Our operating room crew, when they're on call, after 2 months, it's just exhausting. And people need to have a break from it. So that's the problem. Typically what you find is midwives work where there are other specialists able to handle the problems that might potentially come up. And again, it's a might. They might not have a problem, but if they do, we'd have a horrible outcome if we didn't have a physician. That's why it's hard to bring that in and think that you're safe from infection.
Do you have anything on Gerald? Is he doing okay?
I don't have any additional information. So as soon as I know anything, I will certainly let you know. He just wasn't here.
I don't know where it is.
Okay.
I'll be happy to provide additional information at another time. So,
Okay.
does anybody have any problem with me pursuing these searches?
I think you have to.
I thought this was ongoing.
It is ongoing, but I need to escalate. It's one thing for me to keep looking and trying various means that aren't terribly expensive. We're not having success. Now we tried to be more aggressive. That's really the bottom line.
If you do the same thing over and over and you don't get results, you're still not going to get results.
And we're not the only ones that have these troubles.
Yeah.
I mean, my goodness, there isn't a community that doesn't suffer from these challenges. And everyone tries to find a solution. At one of the conferences that we went to, the hospital was located in the panhandle of Oklahoma. And what they did is they went to the Association of Missionaries, those that want to go to Africa or South America, places where they have very, very limited access to health care. And those people that want to come back to the United States and spend a couple of years so their kids acclimate to Western lifestyle, or they have to continue other kinds of reasons. And they partner with a husband and wife that may be missionaries. And they would come to this Oklahoma Panhandle Hospital, and they work for a couple of years, and they go back to their mission, come back. And this is sort of cycling of missionaries. And they found that to be a very rewarding process. So everyone is trying something, especially when we're in remote settings like we are. People from Alaska suffer from this more so than we do.
Do you have some way to rate your headhunters? who's the most effective?
No, just by the irritation level. So when Jen can probably just help, when we get, and I'm not exaggerating, 2 to 3 calls every day. Don't you want to hire us? Don't you want to hire us? Don't you want to hire us?
And from the same company, at the same time of day, every day, 5 days a week.
We
You
need
get
to
to know the
raise
phone
our
numbers.
own.
Pardon me?
We need to raise our own. And I mean, and I know that's years out, and I know that's kind of a pie in the sky sort of comment, but,
No, it's
you
not pie in
know,
the sky.
local people, you know, going to medicine, would love to come probably, you know, that's what we need. Somebody who goes into medicine, wants to come back and practice medicine here. Then they stay.
Without a doubt, that really helps. I can tell you about how Burns is suffering from, they got a great resident, finished up, came to Burns, worked for 3 years, and says, no, I want to go back to Corvallis. That's where my family is. And people oftentimes want to return to where they're from. We're hopeful that the new school in Lebanon will produce a lot of interested clinicians, because they are trying to find physicians that want to practice in rural settings. Unfortunately, 80 to 90% of all of their graduates of their school of medicine, as well as their residency programs, stay within 50 miles of Lebanon. So they're creating a massive population of really well-trained people, but it doesn't help us.
Does Oregon train enough clinicians
No.
to service Oregon?
No, one of the big problems that Oregon has is they can produce a number of physicians that finish their medical school training, but there aren't enough residencies to even keep them in the state of Oregon. So as soon as they leave, I mean, imagine this, if you are a young man or woman who finishes 4 years of college, may find a mate, get into medical school, start medical school. By the time you finish medical school, you may have a child, you may not. And then you get into fellowship or residency, very often you're going to have a child, they have children. And then now they're starting a life and a career, and their spouse may be working in that area where they're doing their residency. They don't want to move. You got to try and catch them before that. Hard to do. And the state of Oregon is struggling with how do they get more residency programs. U.S. residency programs around all over. They came up with a really, unfortunately, foolish, but they thought it was mindful process. If you started a program but didn't keep requesting to increase it, you could not increase it ever again. St. Charles and Penn started back in the, I think it was the 80s, that they got a resident in one position. They have not been able, since that time, to add to their residences. They can have one residency position.
Who's controlling that?
It's controlled on the eastern part of the United States by the university hospital systems that want to control where residents come. Because remember, if you train up really good residents at your facility in your large city, they stay in your large city. And it's a way of supporting your efforts in a large university.
Is that an area where political pressure can be brought to bear?
It's been tried for the last 30 years, and obviously that kind of political pressure has not worked. It's a mess. And rural western United States has really been harmed by that because it's all defined by the eastern, more developed cities, and more developed universities.
Walden's been involved with the medical. I don't know if he is anymore,
Yeah, but there's guys, I think Schumer might be his name. And some of the, people with a lot of political power have wielded it. So that concludes my comments. Do I have any other questions of me?
Any other questions? If not, we stand adjourned. Thank you, Terry. Thank you, Teresa. Thank you, Aaron.